while the ITT population did have benefit, although quite close to the margin of significance. The TPS more than 50% had a crossing, and 2 crossings actually in the hazard ratio. Here it was quite weird to interpret, and wasn't statistically different survival. So then, after we think about adjuvant, what if we try neoadjuvant chemotherapy with the chemotherapy? So that was the idea behind Checkmate 816. I'm not going to extend a lot here because probably everybody's tired of listening about this trial anyways. But so this was a phase 3 trial with newly diagnosed resectable stage 1B to 3A non-small cell lung cancer. This is important. It's still AJCC 7th edition with no known mutations. And the patients would undergo chemotherapy for 3 cycles every 3 weeks, with or without nivolumab 316 milligrams, also every 3 weeks. Undergoing surgery within 6 weeks post-treatment, and then optional adjuvant chemo and or radiotherapy and follow-up. The EFS results showed in the intention to treat population that there was a significant benefit even in a 3-year update for this trial with a hazard ratio of 0.68. The EFS was not reached for the population that was treated with nivolumab versus 21.1 months in the population that was in the control group. And the difference in overall survival was also significant. So, which was quite interesting for this treatment. What's interesting to see, and I'm going to show during the presentation mostly the EFS subgroup analyses, because the OS didn't have a lot of variation. If anything, it was a little bit less clarifying. So here you can see that here older patients or older than 65-year-olds, females, patients from North America and Europe, patients who are stage 1B and 2, squamous cell carcinoma, PD-L1 less than 1%, and PD-L1 from 1 to 49%. Patients, well, TMB wasn't predictive at all. Patients who underwent cisplatin, they all crossed the unit here, so the margin of significance. And then it tells us a little bit that benefit, although there was a tendency of benefit for every single subgroup that was shown, the benefit was mostly driven by younger female patients from Asia, PD-L1 more than 50%, with a higher degree of disease, non-squamous histology that received carboplatin, for example. While NATIM-2, this is a phase 2 trial, randomized trial, for patients with locally advanced, potentially resectable stage 3A and 3B, 8th edition AJCC, without mutations, who would undergo either chemotherapy with carboplatin and paclitaxel plus nivolumab, or without nivolumab, undergoing surgery in about 7 to 8 weeks after the first day of the neoadjuvant treatment, and then would receive nivolumab 480 milligrams Q4 weeks versus observation and then follow-up. NATIM-2 did show benefit in progression-free survival and overall survival. It's interesting that they actually call it progression-free survival here. But it was, anyways, statistically significant difference, and here they did not give a big breakdown of subgroup analyses. Ball and keynote 671. Oh, I thought I had added the Sorry, my English is breaking down because I'm post-call, but I thought I had put in the summary of the trial, but it is also platinum patients from stage 2 and stage 3, so excluding stage 1B, AJCC 8th edition, who would receive neoadjuvant cisplatin or cisplatin-based doublet with or without pembrolizumab, going resection, and then followed by adjuvant pembrolizumab. And here we also see, sorry. And here we also see a significant EFS benefit with a hazard ratio of 0.59, 0.48 to 0.72, 47.2 months in a median for the treatment group versus the control group, re-intervention group versus the control group, the 18.3 months. Oh, here it is. So, sorry. For overall survival, there was a difference, although there is some crossing and the difference is hard to see before the line of 15 months. They start to have some differences here, starting especially in this 2-year line, still not reached for a median not reached for the pembrolizumab group versus 52.4 month median for the control group, hazard ratio 0.72. There was no EFS benefit, especially in never smokers. So with a hazard ratio of 0.77, again, tendency to benefit, however, not a lot of, not a statistical benefit. And TPS almost being positive for less than 1%, but yeah, no formal benefit here. So of course, this is the only the second interim analysis. So there's not a lot to draw from here in a very trustworthy manner. Checkmate 77T is another version of the Checkmate 816. It's patients who underwent who had stage 2A to 3B non-small cell lung cancer, now AJCC 8th edition, with again excluding mutations. That's a very important point. Who would receive basically the same thing as Checkmate 816. So Nivo 360 Q3 weeks plus chemotherapy, going to surgery 6 weeks after the neoadjuvant treatment, and then receiving nivolumab every 480 milligrams every 4 weeks for 1 year versus placebo for 1 year. And they also had survival benefit, event-free survival benefit with a hazard ratio of 0.58, which is very interesting for so far. And number-wise, it was still a normal presentation. You have to see the before the formal publication here. And again, with a benefit mostly driven by or with less benefit now, in contrast to the other studies, so females with least benefit, sorry, females from North America, stage 2, there's no difference in nodal status if it's N0 or N1, then the other status it was beneficial. Non-squamous was also non-beneficial. Never smokers, again, PD-L1 1 or 1 to 49%, and patients who use cisplatin. So here, the benefit was mostly driven by males. Sorry, it's wrong here. PD-L1 over 50% with a higher degree of disease. Here is squamous cell carcinoma, smokers, and received carbo. The Aegean, same idea, but with durvalumab. So 4 cycles here of therapy versus 3 undergoing surgery, and then durvalumab every 4 weeks for 12 cycles. And for this one, also stage 2A and 3B, again excluding patients who were stage 1B. And also, and here we had also an important, statistically significant, benefit from that in event-free survival. That was mostly driven by younger male, PD-L1 more than 50%, Asian, non-squamous histologies, smokers who received carboplatin. NeoTorch is another trial that still needs more data. It's still unpublished, in which patients with stage 2 and 3 non-small cell cancer received toripalimab, 240 milligrams plus platinum-based chemotherapy for 3 cycles, undergoing surgery, and then receiving toripalimab for, again, receiving an adjuvant treatment of platinum-based chemotherapy plus toripalimab. It's not a choice of investigator or just not undergoing chemotherapy, but receiving toripalimab plus chemo for 1 cycle, and then completely 13 more cycles of maintenance toripalimab. And here they showed hazard ratio of 0.4 and their event-free survival. Now, of course, this is quite early still, but they also had an important so they also had an important, almost significant overall survival benefit from their margin of the confidence intervals of 0.999. But yeah, almost there. Maybe they just lack maturity of the data. Once more, the benefit was basically driven by PD-L1 positive, this time PD-L1 positive males, this time squamous cell carcinoma, and smokers. And finally, there's pembrolizumab. It's a randomized phase 2 trial that underwent in which patients under only stage 3 underwent chemo every 3 weeks with 3 cycles with or without pembrolizumab, undergoing surgery, and then the follow-up. So this is only a neoadjuvant trial. And in the presentation at ESMO IO Tech, they showed an event-free survival. There was a significant, there was an insignificant difference in this. It's still very early presentation. Also, we had a 24 mark out here for event-free survival with a hazard ratio of 0.52 from 0.21 to 1.29. So we have lots of data, a lot of immature outcome analysis, and the subgroup analyses are all underpowered for us to actually derive any big conclusions from this. And depending on trial and population, we have a sort of heterogeneous benefit depending on how we look at it. So we decided to do a meta-analysis to try and see if we can add a little bit of power by joining the different data that was available. So we conducted a search in PubMed, Cochrane, and BASE, and major oncology conferences. So ASCO annual meetings, ESMO meetings, and World Conference on Lung Cancer meetings, with the primary objectives to test EFS and OS, and secondary objectives was to do a meta-analysis of subgroup analyses available in at least one randomized controlled trial, especially for EFS. The trial level, we conducted a trial level meta-analysis and an estimated individual patient data meta-analysis. I'll go more into that later. Here's a Prospero IT if anybody's curious. Oh. Okay, so we ended up identifying about 1,700 records, and we ended up with 7 different studies that were the ones that I presented earlier. So pembrolizumab, NeoTorch, the 2 keynotes, the two checkmates, and AGM. And what we did for the individual patient data estimation is conducting a digitization of the available Kaplan-Meier plots with an online tool. This basically manual. And the estimation was done with the R package IPD from KM. So here we estimate Kaplan-Meier parameters at each coordinate, including the number of patients at risk, the number of patients censored when they are available, they seldom are, and the number of events. And the quality control was driven by visual comparison, mean absolute error compared to published hazard ratios. The difference, one advantage of this method is that we can actually evaluate if the proportional hazards assumption is violated. So we can actually run additional analysis on this. And whenever it was violated, we did difference of restricted mean survival time, which is a less parametric test than log rank. So it's very in cost, so it's very useful. And the threshold for survival, so the last time that we ended up analyzing, so that we don't start having very heterogeneous or results that are very driven by specific trials because of the length of follow-up. We limited the analysis to the shortest follow-up time of the available trials. The mean average error for the Kaplan for the hazard ratios was 0. The mean absolute error, sorry, was 0.007. So a 95 interval percent interval with very small difference. There was one trial that we had a difference of 0.2. I actually extracted this one. It's not one trial. It was one graph. I extracted it several times and it was still not very good. It was one for stage 3 patients in one trial. So the total of patients analyzed was 2,995, with an EFS analysis including everyone and OS analysis including 1,645 patients from 4 different trials. For the EFS result, we had a marginal hazard ratio of 0.58, so with a very significantly positive trial, or positive result, from 0.52 to 0.65. We still don't have a lot of results to do a comparison in for the 60 month period. However, we can see that in the 48-month period, we have a 20% absolute difference in survival here. So it's a very important difference for event-free survival. This does not violate the proportional hazards assumption, and it was quite similar to the trial level meta-analysis, of course, because it did not violate proportional hazards. And yeah, usually when you join these, we have a pretty comparable result in the trial level meta-analysis. You see that it is very low heterogeneity measures, so it was a good analysis. The overall survival was also positive. It included Checkmate 816, Keynote 671, Naden 2, and NeoTorch. Again, 0.66 hazard ratio is also very good. 34% reduction in events, with a difference in overall survival in 16 months of about 18%. However, there was a violation in the proportional hazard assumption. So talking about hazard ratio here isn't the best thing. It also isn't very appropriate to do a trial level meta-analysis when I have this violation. So with a difference of restricted mean survival time, we did have a significant value with an overall survival difference, with an overall survival time of 31 months. In 31 months, you already have a mean benefit of 1.24 months. After when you consider the 60-month mark, you get about 0.3 months of difference in overall survival. Yeah, interesting results. Important difference in survival, and looking only at the graph. If we take the mean difference of survival, it's kind of a little bit frustrating, but we still have very immature data. So the subgroup analysis for the subgroup analysis for EFS and OS is summarized here, especially for the individual patient data. We see that results that were displayed earlier are here, but when we take into account EFS of the PD-L1 population more than 1%, it is a very positive value of 0.5 hazard ratio. Didn't violate the proportional hazard assumption, and that is also true, notably, for the PD-L1 negative population. We did see that these patients did not have a statistical benefit in their individual trials, but on joining all the population, but they had a tendency to benefit from joining all the population. They ended up having a significant benefit, although almost getting to the unit margin. Both histologies had a significant benefit. Non-squamous histology has a more positive value. They're not statistically different in the end of the day. What is interesting is that looking at EFS stage less than 3, here we end up having a non-significant value. So hazard ratio of 0.81, but the top of the higher margin of the 50%, 95% of this interval is 1.13. EFS stage 3, that's where I had that the graph that had a little bit more error. Ended up breaking the proportional hazard assumption, but it was fine. It was still positive with a hazard ratio of 0.55. And the trial level meta-analysis showed benefits in all subgroups. This is a difference because they don't publish all Kaplan-Meiers with all analysis, so I cannot extract everything for everyone. But all subgroups, including PD-L1 expression, histology, stage, smoking status, sex, age, everybody had benefit of receiving either neoadjuvant or perioperative immunotherapy. So there's a positive impact with some uncertainty in stages less than 3. We need to see more Kaplan-Meiers and add more individual patient data to be more certain of what's going on. One of the questions that is raised is if we would still worry about PD-L1 in case discussions when we have a patient with PD-L1 low status. And again, what I said about the difference between interpretations in individual patient data and trial level meta-analysis due to data availability. So for next steps would be analyzing perioperative trials only, removing the 2 neoadjuvant only trials, analyzing surgical outcomes, and doing a toxicity meta-analysis. Well, yeah, that's it. Opening up to some questions or comments.
Thanks, Matthias. That was a great presentation. I think we unfortunately didn't have as many people as usual because apparently lunch was not provided. So I think a lot of people were still standing at the kitchen waiting. But if anyone else has any doesn't have any questions, I was just curious in terms of those studies, like when we're talking about PD-L1, because that comes up sometimes in MCC, the studies that showed like the actual individual patient data is supportive that PD-L1 negative does seem to have a benefit, although there's a fairly wide confidence interval. So I guess, are there certain individual studies that you found were like outliers in regards to those results? Like, can we look at how the individual studies differed and whether that might impact how we interpret that. For some reason, we're not hearing you. Are you muted?
Oh, yes, I was. Sorry. Yeah, so there wasn't any weird things like pearls that PD-L1 was not predictive of a good response or something like that. However, I think most trials did not, and with the Kaplan-Meiers that we had, most trials had a tendency for benefit. I did not see a clinical trial that had a positive, a statistically positive and very positive result for PD-L1. I think, and I would need to check this. No, I don't think I've seen a trial that had a big outlier like, oh no, everybody was very, very positive or not. For all those trials where they had a very better tendency to benefit, but always having a slower, a little bit of a tail of the curve crossing the unit here. They were rather homogeneous on that.
Right. So the confidence intervals are generally wider for that.
Yeah.
Subgroup. Okay. And just because you mentioned a toxicity meta-analysis, do you have a plan to do that?
Yeah, I'm going to analyze all the published data for the toxicity and see how big are the difference. I don't expect to see anything very unusual there or any surprises. We do the trials themselves are pretty much homogeneous in that how small the difference in
Yeah, because I was going to say it was pretty encouraging when we had those results come out that a lot of the toxicity wasn't a big factor in preventing patients from getting surgery, for example, which is what we were worried about.
Yeah, exactly.
So
we
not
don't have
as critical.
of surgery outcomes either. But for at least we did see that for the 77T, they did present in the oral presentation. Cunha did present basically the breakdown why patients did not get surgery, and it was a higher number, if anything, in the control group, in the placebo group. So yeah, I think we won't find something very, very different. Some of these trials did exclude, for example, Aegean, they did exclude patients who have planned pneumonectomies. So patients wouldn't be able. So the analysis of the planned surgery versus survival or response might not be very good. However, there is a tendency to a lower number of pneumonectomies in the trials that do allow for that. So, which that can be quite interesting too.
Any other questions from the group?
I just have one, if I can, Matthias.
Sure.
I think you showed us some sort of area underneath the curve or area above the curve, like that one there. Can you? I didn't understand that. That's kind of new to me. Could you describe what you're trying to show? I think it sounds interesting, but I didn't get it.
Yeah. So this analysis is mostly kept to when we have a survival analysis that breaks proportional hazard assumption. So when we're doing an analysis on survival and we're doing, for example, we show a hazard ratio and the hazard ratio is usually performed with a Cox regression analysis.
Right.
And the log rank that we usually do is basically a chi-square test. And the p-value is basically the same p-value of the Cox analysis.
Right.
The Cox analysis, it depends on one specific assumption, that is the proportion of events in both arms must be kept constant through time. So if you have a weird curve like this, for example, let's write in the beginning like this, you see that here you can say, oh, okay, you can have like 2 events in the red line to 1 event in the blue line, but here you have a plateau. So there was a variation in how many events occurred in each line, in each segment of the curve. You can break each curve down in pieces and analyze that way, or you can just use the area under the curve and compare that to try and see how survival behaves. And this second analysis is called the restricted mean survival time. Basically, it tells you if I distributed, basically, like, imagine this is a hill of sand, and if I distributed that in actually flattened it out, where it would be, and it's actually flattened it that way. If I flatten it to this direction, where it would be basically the mean time of survival of the patients. And I would subtract this area from the area from this curve to the area versus the area of this curve. I can use any, since I'm flattening, like I'm imagining like a hill of sand this way.
Okay.
I would flatten it down. Since this is dependent on time, and if I give it more time and have 2 curves of different sizes, I have to set up a threshold or boundary in which I will consider the time. So here we chose the follow-up, the shortest follow-up of all the trials involved, because after that, follow-up starts being rather
limited.
Yeah, it's limited and heterogeneous between trials. So survival starts being weird, like here it breaks down, right? It's basically driven by 1 or 2 trials. So we limit it to that, where you have a quite homogeneous curve to have a more significant / accurate result. I could also run this difference in trials where with the whole curve, it would have when I did, it was about 5 months of difference. Here it's about 1 month. It's still very low, but you can see that even usually in overall survival curves, you start having differences between 2 and 2.5 years. So it's quite still in the expected range, right?
Okay.
I hope it made sense. I tend to ramble on a lot more.
A little bit. That's a bit more complicated than I have time for. But maybe I'll come chat with you sometime about it.
Of course, you're a pleasure.
But I guess this is a brief thing. So I guess are you saying, like, when you showed that curve, are you saying basically like that the assumption is, in a simple way, is it right to say that it's kind of like that the curves if they have a different shape, that's a problem?
Yeah, the problem is it's not necessarily the different shape. Is, for example, if I have 2 different trials.
It's okay, I'll come chat with you sometime. I think I don't want to.
If we're doing 2 different treatments, and one of the treatments has a lot of deaths in the beginning of the treatment, and then it keeps survival better afterwards. And the second treatment has less deaths, but it does worse afterwards.
Right.
It's very hard for us to do a comparison with a proportional hazards assumption with that, because it will assume that the rates of events is similar and this is constant during the lines, when it can vary a lot.
I see.
So the statistical depth test using a Cox or doing a trial level meta-analysis would not be inappropriate. I think we can, especially for long-term survival, that can be a problem.
Okay. Thanks.
No problem.
Any other questions? Okay, we'll leave it at that. Thank you so much, Mateus. We really appreciate your hard work, and it was a great presentation.
My pleasure. Thank you, everyone.
Thank you.